My name is Megan Downey, and I am an executive editor for The Regulatory Review, a daily publication produced at the University of Pennsylvania Law School. Today's webinar grows out of and features contributors to a series of essays addressing the regulatory responses to and implications of the COVID-19 crisis, which we have published in the Regulatory Review over the past few months. In producing this series, our editorial team at the Review has had the privilege of working with today's panel members and many other distinguished scholars from all over the world. Before we begin today's panel, I want to extend a very sincere thank you on behalf of our editorial board to everyone who contributed to this extraordinary series. I'd like to thank Professor Cary Coglianese, our faculty advisor, for all the support and guidance he has provided as we worked to produce this series. I'd also like to thank Naysam Albubi of the Center for the Study of Contemporary China here at Penn for developing the idea for this series and for connecting us with so many of the authors featured. If you haven't yet seen our COVID-19 coverage, please be sure to visit the review at www.theregreview.org. If you haven't already done so, we encourage you to sign up on that website for our weekly newsletter. You can also find us on Facebook and Twitter at The Reg Review. With that, I will turn things over to Professor Coglianese for a few logistical announcements before we get underway.
Well, thank you very much, Megan, and my thanks as well to all of your colleagues on the Regulatory Review for, in an important way, bringing us all together here today with the great work you did on the Comparing COVID Responses series, on a 40-part series covering responses to the COVID crisis by nations around the world. Today's webinar will focus on the responses in the U.S. Before we get started, though, let me welcome everybody who is joining us. My name is Cary Coglianese. I am the director of the Penn Program on Regulation, and I will be pleased to moderate today's webinar. A couple of logistical announcements. First of all, the chat function is activated on your webinar, and you are free to make comments on that will be seen by all the attendees on today's webinar. Please keep the comments appropriate. We will have our staff monitoring that, and we'll address anything that is inappropriate, certainly. Also, while you are on today's webinar, you can ask questions that you can pose to me to ask to the panel members. To do that, you should enter your questions on the Q&A function of the Zoom webinar. Just scroll down toward the bottom of your screen and you should see a panel that lights up, and there's a little option for Q&A down near where you can activate the chat as well. And if you type in questions there, those questions will only be seen by me, but I will be looking at them and using them as a vehicle for framing some of our discussion today. So I look forward to and welcome your participation by asking questions in that manner. Finally, one other logistical or administrative announcement. For those of you who are participating today in seeking continuing legal education credit, you need to keep track of two code words. The first one I will give you now, and it's called goldfish. The second word will be given to you later in this webinar toward the end on the chat function. So look for the chat function toward the end, and you can find your passcode, your second passcode for CLE credit. Again, the first passcode is goldfish. So note that and put that down on your CLE paperwork. With that, I'd like to open things up now substantively and hear from our panel members. The title of our webinar today is The COVID-19 Crisis and Its Implications for U.S. Regulatory Law. And I'm struck with the number of cases and the number of fatalities that we are seeing in the United States at this point in time. As of today, we have approximately 180,000 at least identified deaths associated with COVID-19 in the United States, and about 6 million confirmed cases. The CDC and others have estimated that there are additional unconfirmed cases out there, perhaps on an order of magnitude larger. Since we're going to be focused on structural issues of law, administrative law, and regulatory law, I just thought at the outset it's helpful to frame those numbers. The 6 million confirmed cases equates to about 2% of the U.S. population with COVID-19 disease over the last several months. The relevant risks for regulators in the United States tend to be much, much lower than that. By way of just reference, the U.S. Environmental Protection Agency often tries to ensure that risks are below 1 in 1 million for cancer-related illness. And the Occupational Safety and Health Administration will treat a risk of 1 in 1,000 as a significant workplace health risk. And here we have a risk that's 2 out of 100. So this is a significant risk that we're dealing with, obviously with enormous economic implications as well as health and safety implications. So I'm delighted that we have our 4 panel members here who have each contributed essays to the regulatory review's special coverage on COVID-19. And I want to turn to them to get things started and ask them to just talk a little bit about what they wrote and what the key takeaways are from the work that they have been doing. I'm going to go in the order that was listed on the slide opening up today's presentation. Allison Hoffman, a professor of law at the University of Pennsylvania Law School, will begin, followed by Richard Parker, professor of law at the University of Connecticut Law School, then Alex Camacho of the University of California, Irvine School of Law, and then Rob Glicksman of the George Washington University Law School, professor there. Really delighted to have all of the panel members here. Allison, could you start us with just a bit of an overview of where we are in terms of the U.S. legal system and the regulatory system in particular responding to the COVID-19 crisis?
Sure. Thank you so much, Cary, for inviting me to join today, and hello to everybody. As you all likely know by the fact that you have signed on to this call today, the story of COVID-19 in the U.S. has been one of glaring failure. And some of what we'll talk about today is why, both by diagnosing the drivers of failure in the United States and by contrasting the U.S. to a success story as well. Of those 180,000 deaths that Cary mentioned, I wanted to say that even though this isn't what I wrote about in my regulatory review piece, 41% of those have been in nursing homes, residents and workers. And those nursing homes have suffered, especially in areas of the country with high community spread. And because these homes are understaffed, they lack the equipment and workers. The workers are underpaid and often have to work multiple jobs to make ends meet. And they have become vectors of transmission into nursing homes. So that is one of the many pieces that we can spend more time with later. One of the challenges that we've faced in the United States, and this is certainly not unique to the United States, is our federalist system of governance, where the federal government is not only not helping and controlling matters, but is also undermining some of the good work that some states are trying to do by sending conflicting messages, false hope, and misinformation. So a lot of people have asked the question of what would this pandemic have looked like here with a different leader? And often the answer isn't easy. It would have looked, it would have looked totally different. It would have been way better. We could have looked like other countries, but I actually think it's hard to know for sure because we live at such a moment of such great political divide that if we had a leader who had pushed strongly in the other direction for quarantine and contact tracing and masks and the other tools that we know work from a top down, the kind of pushback from states and from individuals may have been so strong to undermine even a strong federal effort towards containment. So what we've seen obviously is the opposite. And in my own writing, I often talk about the value of solidarity and how it's an anomaly in the United States as compared to other places. And that's become really glaringly obvious at the moment. We still have 30 million people who are uninsured, many more who are underinsured, and it compounds the complexity of diagnosing COVID cases and treating people. And so what I want to talk about is the flip of the example I was just giving, whereas if we had had a strong leader, would the country have gotten behind them? What happens when you have the opposite dynamic effect, when you have a leader who is weak, and then the states step up, even in light of failure of the federal government? So what I'll do is I'll just start today off very briefly with a somewhat positive story of early responses, especially at the state level in some states, as the pandemic started to ramp up in March. And then we'll shift gears to the more dreary picture of how we've ended up number one in the world today. I'm going to focus pretty specifically on health law regulatory aspects, asking the question of how did the medical care system and the state regulation of that medical apparatus respond when we realized that we had a major crisis on our hands. That was the focus of the piece that I co-authored with a recent Penn Law graduates, Simone Hususian, and it still proves true that the states and the healthcare systems are doing some amazing things, even as we stumble collectively and at the federal level. But once we've gotten to the point, I want to be really clear about this, I'm focusing in pretty narrowly on the healthcare system. Once we've gotten to the point of needing the medical care system in the intensive ways we have, we've already lost the battle with containing and turning the pandemic. So even this little story of regulatory success that I tell is in some notes a very small footnote to the larger story of failure, total pandemic control failure in the US that my co-panelists will talk about in a moment. So in early March, when New York City started to see crisis conditions, one of the earliest questions was, will the hospitals have enough medical professionals? Will they have enough equipment to care for the flood of COVID patients? And we saw states respond in productive ways as the federal government was largely punting to them to respond. So let me just give a few examples. These are the examples that we highlighted in our regulatory review piece. There are others as well. One of the things we saw was that we saw states try to help some of those 30 million uninsured that I mentioned. When Simone and I wrote in May, 20 states had expanded their Medicaid programs. Medicaid is a federal and state partnership that pays for care for low-income populations. And the Federal Families First Act, one of the early relief acts, said, states, you can use your Medicaid systems to pay for testing, COVID testing, for the uninsured. And so some states, 20 states, responded and did that. They also, some states, fewer than that, but some lowered barriers for people to enroll in the Medicaid program if they had qualified but had not yet enrolled. And some removed barriers that kept people in these programs from actually getting care, things like fees, premiums, and deductibles that they would have to pay when they went to the doctor or the hospital. A second example that states did was that they waived and revised laws that might compound a shortage of healthcare providers. So usually a professional has to be licensed by and in the state in which they practice. So if somebody moves from one state to another, unless there's reciprocity, they have to get relicensed by that state. All 50 states waived laws that require in-state licensure. So for example, somebody licensed in another state could travel to New York City to help provide care in the early days of crisis. They also amended licensure laws and other laws that define what is called the scope of practice. The scope of practice tells you the outer bounds of what a particular practitioner can do legally. So in many states, and in many cases, nurses, advanced practice nurse practitioners, and physicians' assistants are competent and trained to do much more than the law in that state has allowed them to do. Things like prescribing and diagnosing, especially without the supervision of a doctor. And many states responded very quickly to loosen these laws to let those professionals do what is often called practicing to the top of their license, to do the most of what they're competent to do. And as an aside, one of the things we've seen is when states do this, when they loosen these laws, we also lower the cost of medical care because a nurse or a nurse practitioner can often provide care less expensively than a doctor could provide exactly the same care, sometimes even more competently. The third thing we saw was a rapid movement to and a regulatory loosening of requirements for telehealth. Some of you have probably experienced that yourself. I have definitely during this pandemic. When we wrote, 49 states had waived laws that prohibited doctors from practicing telehealth outside across state lines. Several states waived the requirement that the patient have a pre-existing relationship with the doctor, so an in-person relationship before they could do telehealth. states lifted what are called originating site requirements, which did things like in rural areas, they made patients travel to a health center or a clinic in order to access telehealth. And then some states address what is a major problem for telehealth, which is parity problems in payment, where telehealth is often reimbursed by insurance at lower rates than the exact same in-person care. So these are just 3 examples. They were important steps. They helped the medical care system respond swiftly, but they are clearly only small steps, and they left many gaps even in the medical care system. So for example, even though the Families First Act allowed the states to expand Medicaid to pay for testing for the uninsured, it didn't say anything, and there was no parallel provision for treatment if somebody tested positive. And even though hospitals were able to get doctors on board, as many of you know, some of the early challenges were that they didn't have enough PPE. So they may have had enough people, but not enough equipment to be able to treat people safely. Telehealth expansion is great, but a large number of Americans lack broadband access or the resources to pay for it. So for the medical care system, states took important steps, and they did so quickly. That is a wonderful story of an early success in the U.S. There's a larger question for the medical care system of what comes next. Do these laws that were passed in kind of a temporary way, do they stay on the books? How do we build on these steps in the future prepare for readiness if this happens again, which hopefully it will not, but how do we remain ready in the future? And then how do we combine that with a stronger governmental hand so that we can keep people out of the hospital so they don't have to end up in crisis mode in the future as other countries have more effectively done.
That's great, Allison. You know, I think it's a wonderful reminder, especially as we think about the regulatory implications of this crisis, that there are, in some sense, first order regulatory implications. As you said at the outset, things like work orders, shutdown orders, and contact tracing and other kinds of requirements. But then there are these second order regulatory changes, as you've outlined so well here, in the administration of healthcare, for example, that have to be modified to account for and adapt to this crisis. I thought what we could do now is ask Richard Parker. Richard, if you could talk about what happened in New Zealand, even though this is all about the U.S. here, but your piece in the regulatory review contrasted what has happened here in the U.S. with New Zealand. And so with this grounding in the first order and second order regulatory changes that we've seen here in the U.S. and we've seen in other countries, what insights can we glean from the experience of a country like New Zealand about how well the U.S. has performed?
Thanks, Cary. It's a great pleasure to be here to talk about this very sad topic. I wish the topic were a little more cheerful, but I'm glad to be here. You know, global pandemics, when you think about it, are the ultimate test of government, right? The challenge for every government is basically the same: to protect their population from a deadly contagious disease without destroying the economy. And performance on the test is measured pretty brutally, right? In deaths, hospitalizations, lost jobs. So what I looked at is the story of how 2 very different countries, New Zealand and the United States, fared when confronted with this test. And the contrast is really remarkable. By any measure, New Zealand has passed this test with really high honors. They have a total of 22 deaths from the pandemic so far, with 1,695 total cases. Now, they're a lot smaller, so you have to multiply by 39, right, to take account of population differences. So let's do that adjustment. Let's account for population differences. That gives them a U.S. adjusted equivalent of 66,000 U.S. cases and 850 U.S. deaths. Compare that to the 6 million U.S. cases thus far and 177,000 deaths and counting. So just so far, if we just look at where we are so far, simple math tells us that even after adjusting for population, New Zealand has done 100 times better in preventing cases and 200 times better in preventing deaths. Moreover, and this is the most important thing, New Zealand's crisis is largely over. Until a recent outbreak of 101 cases in Auckland, their largest city, they had virtually no new cases for weeks. So they locked down Auckland till the end of August as a result of 100 cases. That's the cases that we experience every 5 minutes. and no U.S. city is being locked down as a result. Our nightmare continues. So the first question we confront is, well, why was New Zealand's experience so different? And there's a number of tempting sort of alibis that kind of let America off the hook, right? First, New Zealand's an island country. Secondly, they got lucky. Third, they're a rural country. Fourth, they're small. They don't have our population, right? The problem is that none of these alibis really stand up. COVID-19, as we all know, spread around the world by air, not land. New Zealand is a major tourist destination with many travelers from China and Asia. COVID-19 came to them at the height of their tourist season. Its island status was irrelevant, and they didn't luck out. They actually got hit pretty hard initially. By the time New Zealand's government swung into action, they were on a track to experience 14,000 cases, equivalent to 966,000 in the U.S. So New Zealand, just the main reason for the discrepancy, I believe, is that it's not that New Zealand is small or island or they lucked out. Larger countries have done much better than us as well. The main reason is that New Zealand followed the playbook, and they followed it really strictly, and the United States did not. And I think, the basic story will be familiar to us in terms of what that playbook is. But first, they very quickly closed the border to all travelers coming in, including including New Zealand residents, making everybody who entered the country quarantine for 14 days in a government-supervised facility before they could be let loose into the economy. The U.S. has never done anything even remotely comparable to that. That's actually a pretty small issue now because community transmission is so much more important than travelers from abroad. But it was a very important early difference. Secondly, they moved really quickly to establish, they don't have a Defense Production Act, right? But they established a personal protective equipment register to mobilize Kiwi manufacturers to begin churning out all kinds of PPE. And they got their merchants who have links to China scouring and competing and bidding to get masks, all manner of PPE, masks, gowns, everything you can think of into the works. Trump, as you know, did nothing but with the Defense Production Act besides mobilizing a mass production of ventilators, which the Washington Post just tells us today we no longer need. And ventilators are just for people on death's door anyway, and they found other treatment measures. But in terms of other PPE, we're still horribly short. Third, they mobilized a consortium very quickly to scour the world markets to get test kits. While we were still fiddling around trying to get CDC's kits working and ignoring international supplies from around the world, New Zealand was testing at many multiples of our testing rates in those critical early months. Contact tracing. They didn't do anything really high tech. They just had their Ministry of Health do low-tech stuff, the usual stuff that has been done for years. They adopted a high-tech platform later, but their initial response was decidedly traditional, but very effective. You can do that if you act early and the cases are small. The problem of contact tracing becomes exponentially more difficult as the cases proliferate, right? But finally, and I think the most important thing that I really want to emphasize is that they imposed a draconian nationwide lockdown very early that was mandatory, that was enforced by the police, and that was really enforced. And Jacinda Ardern, a communications specialist, sold that policy to the American people, to the New Zealand people by explaining a simple truth, right? That for a lockdown to be short, it must be hard. Her message was, if we go fast and if we go hard, it will be short. A half-hearted lockdown that is not enforced, that is not complied with, will fail. It will prolong the pain until a vaccine arrives. And events proved her right. And you can actually document this by looking at Google mobility data, which is a terrifying but interesting resource on nationwide mobility trends. Shows a very, very high rate of compliance with the New Zealand population during this hard lockdown period, much greater than the United States, even in the early phases before the real resistance to the United States developed. And the results were astonishing. Within 21 days of a hard lockdown, 51 days of transition through lower levels of restriction, they had achieved their goal of no new cases until this very tiny resurgence recently. So that's the main takeaway from New Zealand. The playbook works, but you have to follow it quickly. Shortcuts are not allowed. Lockdowns must be strict. They must be universal. And I'm going to argue they must be centrally directed. And I actually will push back on the other panelists. I really don't think that, and we can talk about it in the Q's and A's, I do not think that leaving it to the states ever had a chance of working. And I do think that if a president as charismatic as Trump is had wished to make this his issue early on, had wished to coordinate a federal response, he could have found the authority and he could have found the political will to do that. But that's obviously speculative. That's the road not taken. But I believe New Zealand stands as a j'accuse for this administration, right? 177,000 people are dead. A lot of them would still be alive if we had just followed the playbook the way New Zealand did. Thank you.
Thank you, Richard. And, I think it's worth noting that it really isn't just New Zealand either, that against many industrial nations, the track record here in the United States fares poorly. South Korea has done well. One of our participants on the call says, and I quote here, "Have you seen the results in Greece? Phenomenal for a small country of 11 million with only 148 deaths before they opened to tourism in July, and now approximate 250 deaths," close quote. So these are just some of the other comparisons. I would invite anybody who wants more comparative work to take a look at the regulatory review series. I think it's instructive, Richard, as you say, to do that comparison to see what might have been or could have been here in the United States. Alex, let me turn to you. If you agree with Richard that the U.S. has fallen flat-footed here, why is it? And you and Rob have written and published a recent book, Reorganizing Government, a Functional and Dimensional Approach. And your essay in the regulatory review emphasized some of those dimensions that you see contributed to the failings in the U.S. Can you get us started?
Yeah, great. Happy to. So let me also say, like the other panelists, that it's really great to talk with others constructively about how to improve government in these times. I mean, it certainly feels productive to be able to think of it that way, despite the discouragement that one might look at just out when turning on the news. But so Rob and I have been thinking for years about the important features of allocating government authority. As Cary mentioned, we published a book on it generally. And more recently have drafted essays about its significance or relevance to pandemic planning and response. And I guess sort of the punchline I will say is, to sort of riff on what Richard said, is the U.S. didn't just not follow the playbook, it buried the playbook and disbanded the authority that drafted the playbook. I'm talking about the federal government here. So what I'm going to do is I'll focus first on quickly describing the sort of the framework that Rob and I have come up with for thinking about allocating government authority. And then Rob's going to talk about its bearing, particularly in the COVID-19 context, okay? So we think that there are sort of two broad categories for thinking about the allocation of government authority, okay? And the first one really emphasizes what we think is the need to focus on what we call functional jurisdiction. That is that legislatures, agencies, and more generally academics sort of focus mostly on what we call substantive jurisdiction or authority. So air pollution, immigration, or in this context, maybe disasters or pandemics or public health. But another way of understanding authority is based on the particular governmental function. So what we mean by this is the tasks that the government is engaging in. So not just is it involved in pandemic planning, but what sort of functions is it doing? Is it talking about funding or financing, or talking about scientific research, information compilation, information analysis, planning, standard setting, enforcement? There are various different others that we sort of detail. And so this one relatively simple point we think is really underappreciated in the literature that sort of looks at the allocation of authority. Especially just the very basic point that any allocation of government authority involves both a substantive and functional allocation. It's just not often explicit. The second sort of component of this framework is thinking about, we sort of focus on what we call dimensions of allocations of authority. So these are really on a continuum, as dimensions are, right? And there are really three that we say exist. So the first one is probably quite familiar to everyone here, and that is questions of scale. So how centralized is the authority that you want to give? Is it decentralized on the one end to the local government, or is it more at a national, even international level? So the focus is usually on determining the right regulatory scale. In the United States, this is often as an issue of federalism, right? But we also point out that, this question, whether it's decentralized or centralized, isn't just a choice between government levels, federal versus state. It's also a choice within a level. So within the federal government, how centralized or decentralized should the authority be? So that's the more familiar dimension. The other two dimensions, well, the second dimension is what we call sort of arranging between more overlapping authority and distinct authority. So an agency's authority can be more or less overlapping with the authority of another agency. And this has been increasingly a popular feature of analysis in the federalism literature, with talking about things like floor preemption or ceiling preemption, where the federal government may set a floor and states may regulate more or less. But the overall point here is that this is distinctive from what level of government should be involved. It often might be, well, should more than one level of government be involved, or more than one agency or authority be involved? And the third dimension is between sort of independent authority and, on the other end, coordinated authority. So this really looks at how much do regulatory authorities coordinate on different government functions, right? So on one extreme, you could have no coordination, more fairly independent authority, and in other, you could have a lot. But that coordination piece is often thought of as being very similar to centralization. And we point out that, in fact, coordination is distinctive from the question of centralization. How much you coordinate. Is it formal or informal coordination? Is it short-term or long-term coordination? Is it voluntary or required coordination? Is it frequent or less frequent? Is it horizontal between two authorities of relatively similar scale? Or is it hierarchical with one agency telling the other one what to do? These are all very important considerations in thinking about addressing a regulatory problem, okay? And more specifically, there are certain trade-offs, pros and cons, that are raised by moving along each of these different dimensions. And unfortunately, when designing government, routinely scholars and policymakers often conflate these different dimensions and trade-offs that exist. Okay, so our book and essay, which I will now turn to Rob for, which really shows how this framework can help promote more effective governance, preventing or helping people see how not to conflate and think about the different trade-offs separately.
This is a great, actually, moment for me to intervene with just a quick clarifying question that one of our audience members has asked, and it may well be answered by Allison as well as Alex, you or Rob, and that is, where have some of the changes in regulatory law or law and all, where have they been made? So Allison, you talked about a number of changes in the health care regulatory structure. Have those been made by regulatory agencies at the state level or by legislatures? Overall, where has been the center of gravity for legal responses to this crisis in the framework kind of that you were talking about, Alex, especially the spatial dimension, mostly at the state level, but even within the state level, then is it more legislative or regulatory?
I will just say really quickly, and I'm sure Allison can speak to more generally as well, that I think it's been happening at all scales, right? I mean, we're talking, when you actually think about this actually gets at what Richard sort of started with saying that this is an ultimate test for government, that, a pandemic in many ways hits at every scale. It hits, from the local school district all the way to the federal government. So I guess I don't know if anybody could come up with a tally as to where the legal gravity has been centered on, the inertia. I think it's been at every scale and by each branch of government. Obviously, there's been court cases as well.
Right.
I'll just interrupt quick second. Just to keep you in suspense for another minute or two, but we think that a key change, which was misguided, took place within the executive office of the president. And I'll describe that in my presentation.
Right. Okay. Allison, do you want to just clarify the site of a lot of the changes that you've been highlighting?
I can say a lot of the things I have been talking about were not happening in the state legislatures. They're happening more through state regulation and also from the governors through executive action. I see Tim Jost is on the call, so he can correct me if I'm wrong on this because he's the expert on healthcare. But the state legislatures have done some productive things, but from what I've been watching, it feels like more is happening. Like the Medicaid work happens within the regulatory agencies for the most part. And for example, some of the scope of practice that I was talking about were governors using executive orders to waive existing laws.
Right. Okay. Back to you then, Rob, then to continue with the framework that Alex had presented and then applying it to the COVID situation.
Okay. Well, thanks, Cary, for inviting me to participate. And thanks to Alex for setting up the rest of our presentation. So we've heard from Professors Hoffman and Parker that there are a lot of reasons why the government of the U.S. has performed so much more poorly than most developed nations elsewhere in responding to the coronavirus. And they include things like the government's slow response and its unwillingness to listen to expert advice. But we think the administration's structural choices have been a significant contributing factor. And we think they provide a stark reminder that the design of government institutions and programs is critically important to the success or failure. We believe the administration's poor choices in allocating authority along each of the three dimensions that Alex described hampered an effective pandemic response in the U.S. Now I'll get to what I said was going to come a minute ago. Mm-hmm. We believe the Trump administration made a literally fatal choice in early 2018, well before the virus appeared. In an effort to streamline the National Security Council, it disbanded the Obama administration's Directorate for Global Health Security and Biodefense. Doing that eliminated an entity whose sole job was to prepare for and lead a response to pandemic outbreaks. The administration consolidated the directorate into a larger National Security Council entity whose responsibilities included weapons control, non-proliferation, and anti-terrorism matters. As one official put it, that centralization of authority decapitated and diluted the White House's prior focus on pandemic management. Dr. Anthony Fauci, who all of you are familiar with, once remarked that he wished the directorate still existed. While the administration made that unwise choice in the direction of centralization of authority within the executive office of the president, it at the same time basically outsourced to the states the responsibility of managing pandemic response. Now, decentralization, at least of some functions of government, may have allowed state officials to conform responses to local conditions and encourage different approaches among the states to experiment, see which ones work best and which ones don't. But at a minimum, functions like generation and distribution of accurate scientific information should have remained centralized to take advantage, among other things, of economies of scale. Along the second dimension, the administration created overlapping federal authority. At various times, the HHS Secretary Azar, Vice President Pence, and Jared Kushner all seem to be in charge of the federal government's pandemic response. Now, overlap isn't necessarily an unwise choice. It can provide a safety net against inaction by a single entity. But it can also result in wasteful duplication of effort and the issuance of conflicting mandates. So these are some of the trade-offs that Alex mentioned in moving in one direction or another along a single dimension. In this case, the creation of overlapping power centers within the federal government resulted in, we think, first of all, a lack of accountability, and second, the appearance of conflicting directives to private actors like hospitals in terms of how they should manage the pandemic response. Finally, along the third dimension, first of all, we think that allocation of authority along one dimension has the potential to offset adverse aspects of allocation along another, such as decentralized and overlapping authority. Here, coordinated leadership by the federal government could have preserved the advantages of decentralized and overlapping authority while mitigating the disadvantage of those two allocations of authority. But that never happened. No arm of the federal government took on the role of coordinating the actions of federal agencies, state and local governments, and private entities like hospitals. Absent coordinated leadership at the federal level, no one could be held fully accountable for the dismal response we've seen. Uncoordinated planning, for example, for the distribution of medical equipment, left states scrambling for themselves and in some cases bidding against each other to try and get a leg up on other states for access to those supplies. So thoughtful allocation of authority requires careful consideration of the trade-offs of allocating authority along each of the three dimensions that Alex described on a function-by-function basis. The Trump administration's management of the pandemic was devoid of that kind of analysis, as largely decentralized, overlapping, and uncoordinated authority emerged from its reluctance to be held accountable for the U.S.'s response to the COVID-19 crisis.
Okay, that's a lot of sources of opportunities that we could have pursued and done better. One of the first questions that has come in from the audience, and I want to pose to the panel, actually follows from this discussion about federalism and coordination. The states actually have the primary responsibility for public health protection. They have the general police powers and so forth. And frankly, they also have more of the capacity probably to address public health kinds of problems. There isn't quite the same level of ability for the federal government to monitor everything that's happening throughout the whole country. But then we also have, the questioner poses, a right to freely travel around the United States. Can we really ever address a pandemic adequately if we have people who have an ability to travel anywhere? There's still, and there have been, planes flying throughout the country, people moving, the roads are open. Can we get this under control in a system where even at just a level of coordinating people's movement, it can't easily be done? What's the response that on that matter that you would offer? Richard, you want to take that on?
Yeah, I think it's a great question, and I think it really, really underscores how hopeless it is to try to beat a pandemic by a decentralized response. I've had a team of research assistants studying the various state responses for weeks, collecting which states locked down when and how they did it and how much they did it, through which they enforced it. And the answer is they're all over the place. The states are absolutely all over the place in terms of when they started the lockdown and how strongly it was enforced and what form the lockdowns took and what form the restrictions took. And the problem is with a pandemic, it's like a waterbed. You push it down here and it pops up there. And free travel is the mechanism of transmission for the COVID from one place to another. So you see states scrambling. You see New York now requiring that everybody come into the state be quarantined. Well, good luck enforcing that. How do they enforce that? Do they have checkpoints on the road? No. Connecticut now has a quarantine for certain out-of-state travelers, which is absolutely unenforceable and absolutely unenforced. So the question is a really, really astute question, and it just points to the absolute need for a national response. And I don't know how you coordinate states without commandeering them. That's the problem, and you can't commandeer them. And I don't know of any country that has actually beaten the pandemic or even come close by a decentralized response. So I think the burden of proof is really on those who believe that states could do this alone. And I think that question really highlights that.
And Rob, you want to comment on that too?
Yeah, my primary area of research and teaching is environmental law. And one question that's central to environmental law is whether we need federal authority to be involved, and if so, in what way. And there's a lot of controversy over a lot of what the federal government does to control the harms caused by pollution. But one of the least controversial areas of federal authority is the need to control interstate spillovers, which is essentially what Richard is talking about. And so if there's a justification for federal authority, I think that would be the strongest one here, the need to control interstate spillovers. Having said that, I think it's useful to think about the scope of that authority on a function-by-function basis. And so Cary started off by saying that it's going to be impossible for the federal government to do all the monitoring that's needed to control the pandemic. That needs to be delegated down to the state level, but it might be more appropriate and feasible for the federal government to issue standards for things like when lockdowns are necessary or when restaurants can open, that then the states either can be required to follow or are advised to follow.
And I should add that we have some audience members on the call today from Canada, one of whom has pointed out that Canada is a federation and it's doing better. Well, they didn't say this, but I'm pointing out that, yes, that they are doing better, right? No, but the questioner here is appropriately humble and not sort of rubbing it in, that they seem to be doing okay. Why? Anybody want to speculate why Canada was able to handle this and the U.S. Has been unable?
So I'm not familiar with the Canada circumstance, but what I will say is that, I mean, in addition to what Rob is saying regarding sort of thinking about the question of what should you centralize on a function by function basis. So, maybe having standards at a federal level, but enforcement or other things that are at a more local or state level. There's this point that I think is important, that I think what our framework is trying to get at is that, it's not just a question of federal or state, right? It's also a question of when should it be the federal and state. And I think what Canada, from what I've seen, again, I'm not a Canadian law expert by any stretch, or certainly, but what I've seen a little bit more is that Canada has been willing to have a federal response that also allows for the possibility of state responses. And so it's not, I think the challenge one of the challenges we're trying to address with our framework here is that one of the common responses that, no, shouldn't be the states, it should be the feds. And our answer is like, why can't it be both? And more precisely, why can't some functions be handled just by the feds, others just by the states? And which functions should be handled by both? And what does that look like?
And, I think it's a great point, and one that also calls to mind that even without looking across any borders outside of the U.S., we can see within states themselves this tension as between the local authorities and the state governments. We have some states where there has been, a real contestation between those levels, and then other states where it has been more coordinated. And I think the point you just made, Alex, would apply there as well. A couple of questions about the healthcare setting that I wanted to toss out, and maybe direct toward Allison, in fact. One question was if the U.S. had a healthcare system that provided coverage for more Americans, if we had, something like maybe a Medicare for all or just overall, how would that have affected the response to the pandemic?
So that what I think likely would have happened was more people would have sought out testing and care, and we would have seen maybe not fewer cases, but fewer deaths coming from those cases. I mean, it's hard to know how many people didn't go get tested or didn't go get care because they were uninsured or were afraid of the medical bills if they're underinsured, or because of their immigration status as well. A lot of people are afraid to seek out care for that reason. But anecdotally, I've heard quite a lot of that. So it may just be that, that's kind of like you're already down the path pretty far once you get to the point that somebody needs medical care. Ideally, the regulatory responses will jump in far upstream from there. But my bet is that we would have had fewer deaths in that scenario.
Let me follow with another question, slightly orthogonal, but related to your work on long-term care facilities and nursing homes. What do you think might have been done, or maybe even still should be done, to address the risks to residents and workers in those facilities? I mean, did we really need to see 41% of U.S. fatalities coming from that population?
Yeah. So thoughts on that, although there's one more thing actually, as I was the last question, is that one of the places where we may have seen a difference was in the disparities on, we've seen huge disparities on who has died from and who has contracted the virus in this country. So some kind of universal coverage might have helped in that regard, and also in the nursing home capacity as well. Can
I interrupt for just a second on that last point? I think it's important to recognize too that the disparities in fatalities may be associated both maybe with direct access to care once one is sick with coronavirus, but it may also be related to the pre-existing or underlying health conditions that could have been improved with greater access and more fair and distributed access of medical care.
Absolutely. We're seeing a lot of evidence on that. And on the nursing home question is hard. I actually have a piece in the Philly Inquirer today, co-authored with Rachel Werner, who's a colleague at Penn and the head of the Leonard Davis Institute, on why this pandemic should not be reason to close down nursing homes altogether, why we need nursing homes, and what could be done differently in the future. And I've written about that and thought about that a lot. And that's an easier question. The harder question is the one that Tim Jost has posed, which is, once you start to see it hit the nursing homes, what could you have done to avoid infections and deaths? And we've seen, what makes this a hard one to answer is we've seen this happen in other countries that have managed the pandemic better than the U.S. has. Their nursing homes have still been hit hard. And what you might imagine was that like these high quality nursing homes weren't really affected and lower quality nursing homes were just devastated. And the evidence isn't showing that either. What could have happened once we started seeing the effects in nursing homes was prioritize getting PPE and testing to nursing homes. They are still now reporting shortages in PPE and testing, which is just amazing. We could have paid hazard pay to the workers in the nursing homes who were underpaid. They were understaffed before the crisis began, and then many people were not able to juggle the many pieces going on in their lives, and so they lost staff after the pandemic began. So had you increased pay, you could have held on to necessary staff and also reduced the need. I think something like 20% of people who work in nursing homes work multiple jobs. So you could have reduced the need of them to work multiple jobs and then more likely become a vector of transmission into the nursing home. You could have reduced the use of nursing homes for short stays for people for post-acute care. So nursing homes do two things. They are long-term homes for people who need longer-term care, and then they provide pay for a short period of time for people after they've been hospitalized. And the federal government actually put payment incentives in place for them to take more of those people coming out of the hospitals, but maybe that wasn't a wise policy if what you're really thinking of is reducing transmission into the nursing homes. And the last thing I'll say, and one that is more controversial, and I've written about with Jason Karlowicz and David Grabowski in the Washington Post, is to let family members back in more quickly. So CMS put restrictions on family returning that were pretty stringent, and family provide a lot of the necessary care that people need in the nursing homes, and they can provide the first warning if there is something going awry. And one of the first responses, understandably, was to shut the doors completely and allow none of them in. But we think that the policies to allow family back in again have happened too slowly and have led to more deterioration of patients from COVID and other conditions, and also could have helped the nursing homes to have just more people on hand to help, and also to be able to flag if there were particular conditions in the nursing homes that were risky to the patients in the homes as well.
We just have a few minutes left, and I would like to try to get two questions out on the table in the time we have left. So short responses: how will recent controversies over White House pressure on regulatory agencies like the FDA or public health agencies like the CDC affect the U.S. federal public health regulatory system in the short term and the long term? We see with the FDA, for example, this week, convalescent plasma, for example, getting an emergency use authorization after what appears in all media accounts being significant White House pressure. Is that something we should worry about, or is that a good thing, a bad thing for the short term and for the long term? Quick responses. Alex?
I'll just say that the politicization of science, in particular over the past few years, has been particularly problematic on a lot of different areas. So it certainly seems to be the case with that in this context, it's deeply problematic. It does make it hard to address a problem like a pandemic quickly and effectively if people are really distrusting where the reasons for why a decision is being made.
Rob?
I would bring up 2 points regarding judicial review of agency decisions that I think are responsive to your question. On the one hand, the Supreme Court in the last few years has weakened the ability of Congress to create agencies that are independent of executive control. And I think that promotes politicization of the decisions on the part of agencies that previously were independent agencies. Countervailing that, the court has applied judicial review standards in ways that make it difficult for agencies to reverse course dramatically without providing evidentiary support for those policy changes. And I think that's an encouraging move.
Mm-hmm. Okay. And Richard, let's shift to my last question for you. What are the lessons going forward? If there is, for example, a new administration in the White House in January, what lessons should we take away from what we've seen so far for regulatory policy related to COVID-19 going forward?
So I think the two main lessons are, first, the wisdom of what Rob and Alex said earlier, which I concur with as a clarification and refinement to my point about the nature of federal responses. It's fine to cooperate and coordinate with states so long as there is a federal minimum. But there has to be central direction. There has to be minimum standards where the pandemic can't be controlled, and the states can be enlisted in helping with that. But there has to be somebody at the wheel that's central. Secondly, there's going to have to be, until a vaccine is present, there's going to have to be some sort of emergency standards imposed, not only on nursing homes, but on meatpacking plants, on grocery stores and restaurants. There's going to have to be some guidance, some much clearer guidance given now. For how all of us, the workers and customers, can stay safe in these places while this out of control pandemic is with us, and that's going to have to be the central priority of the Biden administration, if there is one, in the spring. But the pandemic is now out of control in this country. We can get it back into control, but there has to be now a new modus vivendi with this virus, since it's not going to be eliminated in this country anytime soon. And that requires, OSHA, for example. OSHA has been unable to issue any emergency standards to protect workers in 20 years. So it's going to have to be OSHA, or it's going to have to be some new agency created, but there has to be some standards for how we stay safe in this environment.
Okay, well, thank you, all the panel members. I will return to a point Professor Hoffman made at the outset, which would be to think counterfactually of what might have happened if it had been a different administration in office, even in January or February. There would still have been certainly a lot of political contestation, and certainly a Biden administration, if there is one in office in coming January, will face that kind of controversy and politicization of this whole issue going forward. And arguably, and this may be my last thought and it's question for everybody to pose, in the end of the day, what is the role of regulation, and what has been the role of regulation in responding to this pandemic, as opposed to good, clear public health risk communication, and perhaps just general public reaction? How much can we say the shutdown of the economy in the spring of this year was due to any governor's orders, or was it due to the NBA canceling its play, for example? Questions to think about, because I do think it's a mix of government, law, and social and public reactions, and good communication through all of that. Those of you who are joining us on the CLE, taking this for CLE credit, look on the chat for your closing password. Those of you who've asked questions on the Q&A that we didn't get to, we'll capture those and I'll share those with the panelists, and they may be able to follow up with you. For all of you who've joined us from across the United States and around the world, thank you for doing so. And thank you to our panelists for helping us get some light to this very important and sad but nevertheless, vital conversation that we had here today. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye, everyone.